Good evening, everyone. Good evening. Well, good evening, everyone, and thank you so much for being here. And thank you for being a part of all of our great conversations that we have been having this week for Black maternal wellness this particular week. And we are so excited and delighted about today's interview. I know the girlies have been talking, they've been asking, because, baby, quite a few of my friends and I, we are in that phase of life, women of a certain age. And so tonight, we have been waiting for this conversation with Dr. Arie Shaw-Miles, and we are looking forward to gaining more knowledge, being empowered with knowledge so that we're able to make the best choices and decisions as it relates to our body. Thank you so much for being here. Hey, a few things before we get started. If you have not liked the NELA Black Maternal Health page, why don't you go ahead and do us a favor, friends, and like the page. Also, go ahead and share this stream on your timeline. Hey, go ahead and share it on Instagram, TikTok, everywhere, because we need everybody in on this conversation because we got things to do and our bodies got to be in order, honey. So go ahead, make sure that you're sharing, and we're going to go ahead and get started. Thank you so very much. Before we start with the interview on today, I am going to read a little of the background information on Dr. Shaw-Miles on today. We are so delighted to have her in our community as well. And so here it goes. So Dr. Arie Shaw-Miles is a board certified obstetrician and gynecologist and a Menopause Society certified practitioner, recognized for her leadership in advancing women's health, particularly in midlife care and health equity. She is a proud graduate of an HBCU, Xavier University of Louisiana, and earned her medical degree from the University of Rochester School of Medicine and Dentistry, where she received the award for outstanding performance in obstetrics and gynecology. She completed her residency at the University of Tennessee Health Science Center and was recognized for her excellence in gynecologic surgery. She also serves as an assistant professor at LSU Ochsner in Monroe in the Department of Obstetrics and Gynecology. Dr. Shaw serves as the medical director of midlife services at Pomelo, where she leads clinical strategy and builds scalable, evidence-based care models for perimenopause and menopause. She sits at the intersection of clinical medicine, digital health innovation, and popular health with a focus on closing critical gaps in care for midlife women. Dr. Shaw is known for translating complex hormonal science into clear, actionable guidance for both her patients and clinicians. Through her platform, Dr. Shaw MD, she actively is reshaping how menopause is understood, discussed, and treated while centering evidence, access, and culturally responsive care for Black women. Yay. Her clinical interests include high-risk obstetrics and long-term health implications of midlife hormonal transitions, including cardiovascular, metabolic, and bone health. She is deeply committed to improving outcomes for African American women through education, advocacy, and systems level change. She is the founder of Umoja Collective, a community centered initiative designed to support women through the menopausal transition with connection and accountability. Outside of medicine, Dr. Shaw enjoys traveling, wellness experiences, gardening, and spending time with her husband, Brian, and their Yorkie Saint. She's a member of the Alpha Kappa Alpha Sorority Incorporated and is committed to lifelong service and mentorship, including her work with guiding young women through her work with Teen Talk. Ladies, and if we even have a few gentlemen, let's welcome Dr. Arie Shaw-Miles to the stage, our virtual stage today. Dr. Shaw, good evening, and thank you so much for being here with us.
Hi, good evening. I am so happy to be here. So always just excited to connect with the community. So I welcome this.
Yes, 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 and we welcome you. And so we're not going to prolong the time. I would like to tell the audience, if you have questions, go ahead and start dropping them and typing them in there, and we'll be sure to get them as we go on. This is an interactive conversation. We want you to feel free to put those comments, those things you may want to amen, you might want to ask a little deeper. This is the opportunity and time for us girlies who are in that season of life. And we have one of America's premier, foremost gynecologists, obstetrics as well, in the room with us. And so we're going to take full advantage of it. So, Dr. Shaw, thank you again so much for being here. So,
Absolutely.
we're going to start with this. There are so many different specializations in women's wellness. Um, what made you being a woman, of course, I want to look at this a little closer when it came to studying, in particular, perimenopause and menopause.
Yeah, so that's a great question. I think what really drew me in was the disconnect between what women were experiencing and what they felt that the healthcare system was offering, right? So
Mhm.
I'm an OBGYN. I am trained in pregnancy and surgery and menopause, which affects every woman who lives long enough to go through it. But I found that there was a lack of knowledge of who to turn to ask questions and also a lack of access. And I really think this had to change. So for me, it all really became about equity and quality of care being received by patients. And so I feel like if we can support women through fertility and childbirth, right? We got that. We should absolutely be able to support them through midlife transitions with the same level of intention and with the same level of expertise and with the same level of access. And I want all women to know that it is accessible, it is attainable for them. And so that's what really drew me into this work.
Absolutely, absolutely. Thank you so much for accepting the call to the work that you are doing. So, just to kind of piggyback on something that you said, and I'm always interested in what causes gaps through the years that you have practiced. Where is it that you are seeing the gaps, and what do you think is causing that to some degree?
Yeah, I think it's a lack of access to providers who feel comfortable talking to women about
Mm,
menopause and perimenopause. Number
ah,
two, it's where we get our information from as patients, right? And so if you think about Black women and Black families, we're cultural, right? We
yeah,
tend to
yes,
discuss some things with our friends, with our girlfriends, with our,
yes,
with sometimes with our parents if they gonna talk about it. But
right.
and so we get those things. So that's either good information can circulate throughout the community or there's bad information that can circulate through the community, right? You have the ideas of the older generation, gray and bear, do those things, and then you have the ideas of the newer generation. And so it's like, where do we turn to get evidence-based, accurate care for this stage in life, right? If I can't find it in my community, I find it in the healthcare system, but then who do I go to in the healthcare system? Is it my
Absolutely.
primary care
Absolutely.
doctor? Is it my specialist? Is it my OBGYN? I don't know. And so I think that those things have to be more recognizable.
Yeah, absolutely. Absolutely. That very, very good point. So let's go ahead and kind of shift gears for a moment and let's talk about some of the science. So in your work, you often break down, the hormonal shifts in your public platforms where you talk about this. But we need to know specifically, how do you define perimenopause in a way that women can clearly recognize that, okay, I'm in that season of perimenopause when their bodies are starting to go through those particular changes.
And changes, they really are, okay? And I think that we have to start with menopause. And so, menopause, by clinical definition, is just the absence of menstrual cycles for 12 consecutive months. On that day, you are menopausal. Every day after that is postmenopausal. But perimenopause is the time leading up to that. And what I try to explain to patients is our brain tells our ovaries what to do, our ovaries tell our uterus what to do. That's a cycle, right? And so when the ovaries are working and they're working well, then everything is functioning normally as we see it, right? We're having our cycles, we're going through the motions of day to day. Menopause is when our ovaries decide to basically go into retirement. They're no
My
longer
Lord.
producing they're no longer producing the hormones that they normally produce, estrogen and progesterone, right? So
Mhm.
when you don't get that estrogen and progesterone produced, then the uterus, remember I told you the brain tells the ovaries what to do, the ovaries tell the uterus what to do, it's not doing what it's supposed to do, right? We see that absence of cycles. Now the reality is that there are estrogen and progesterone receptors everywhere in our body. We as women, we most recognize it with our cycle, but there are estrogen and progesterone receptors in our brain, in our heart, in our skin, in our bone,
Hmm.
okay? Perimenopause, the time leading up to menopause, I like to say the ovaries are basically like using up their PTO before they go on vacation permanently, okay? Before they retire. And
Good
so the
analogy.
brain that tells the ovary what to do is much like HR or your manager, right? So it's
Mhm.
basically screaming to the ovaries, look, are you coming to work today or not? And they're like, sometimes they're working, sometimes they're not. And so we get these wild fluctuations in hormones that causes all of these changes and symptoms. And the things that, and I probably shouldn't say this, but I talk to my patients very real. The part
Yeah,
that
be
sucks
real.
about it is that it's all happening at the same time. So all of those fluctuations in hormones affect not only our uterus and our cycles, but it also affects our brain, our hot flashes, our
Mm.
bone health, all of those things. And that's why it's such an overwhelming time period for women, because it's all happening at the same time, motivated and fueled by those fluctuations in hormones.
Gotcha. Gotcha. Oh, that was real good. That is a lot that is going on with our bodies all at one time. So it it proves in many cases why I would say particularly perimenopause, because I remember having that conversation with a GYN I had, and she didn't know what I was talking about. But many times, and I think because there's more conversation now around that, uh
Hmm.
there may even be a bit more study, or even for uh, uh doctors who are looking to better serve their patients, being able to do more research on that. And so
Absolutely.
with that, let me ask this question. So, what are some of the earliest signs of perimenopause? Like, when does it normally take place, and why is it commonly overlooked and misdiagnosed?
Yeah, I think that is a great question. So the average age, and I always start with menopause, like right? So the average age of menopause is like 51.2. That's what we quote. But perimenopause, the time leading up to that, can begin sometimes 10 to 20 years before that, right? Late
Mhm.
30s, 40s, that kind of time. Changes that we may normally see, the most significant one that we usually see is menstrual period changes. So our periods become more irregular, less predictable. Sometimes one of the early signs and symptoms that we can see is sleep disruption, right? Women who have
Oh, Lord.
always slept well, they suddenly wake up at 2 or 3 a.m., right, and can't fall back to sleep. That alone can drive the fatigue, the irritability, the brain fog. Then you have mood changes, right? Anxiety and things like that. And a lot of times these symptoms, based on what our baseline health is, can be kind of roped into or explained away by some of our other diagnoses. And a lot of
Mhm.
times with women, our symptoms get labeled as stress, burnout, depression. Maybe you got ADHD, right? Without recognizing their hormonal contribution to the symptoms. And it's so easy sometimes for people to explain away the symptoms of women. And I can tell you that's one thing that makes me really upset. Really, really
Well,
upset.
talk to us.
But yeah, and so that's what makes it hard, and that's what makes it overlooked and misdiagnosed, right? But what does that mean for us? It means that women, we as women, we have to be diligent in tracking our symptoms, knowing what we're looking for, and being educated about our body and the signs and symptoms that may occur, and tracking those things, right? So that when we go to the doctor's office, or when we go to the provider's office, we're coming in with not just like I feel different, but no, I'm not sleeping. I'm awake from 2 a.m. to 4 a.m. This happens to me on week 3, 4, and 5. And that kind of thing. And we have to be detailed in that so that we know exactly where to begin, right?
Right, right. And that's and that brings up a important point about being your advocate, and being really a
Yes,
champion for your own health, because
absolutely.
yes, because as you are saying, the more specifics that you can give your healthcare provider, the better able, in most cases, they're able to help you get to the bottom line of what's going on. And I
Hmm.
think that is, I think that as my own personal journey, that has been key to getting some solutions. In addition to, firing healthcare professionals, because I don't have a problem with that at all. Yes.
And
So
and that's the thing, like tracking symptoms over time can help us create a more clear picture, right? And
absolutely.
so being able to define exactly what it is that you're feeling is very helpful. And you're right. If a provider isn't as responsive, it's okay to seek a second opinion. I tell my patients, like, grab a second opinion. That should not be offensive to anyone,
Yeah.
right?
Yeah, absolutely, absolutely. And I think, I think when you have a provider that's okay with that, you are going to get, a well-rounded healthcare experience
Mhm.
that I've seen time and time again. Thank you so much for sharing that. So,
Absolutely.
so you've described this a little bit earlier, but I want you to, if you could, go in a little bit more into depth about what the main differences are between perimenopause and menopause
Mhm.
as well, because I know in some cases I've heard some of my friends talk about where it feels like they're sometimes all kind of wrapped up in one. And then when you began to look at that, like clinically, what else defines that says, okay, this woman is strictly in perimenopause, this woman is in menopause for her. What?
Yeah. So I think this brings up an important question about what definitions are and how things can get confused, especially with menopause having this moment right now. That's what I like to say. It's having a moment. Everybody's talking about it, but not
Yes.
all of the information that is being portrayed is accurate or evidence based. And I think it's really good to go back to the basics. So clinical, these both are clinical diagnoses, right? Clinical definition of menopause, absence of period for 12 consecutive months. That's it. That's it. We can look for other signs of that, which lab values and things like that, that may help support the diagnosis of menopause. And then perimenopause, kind of the same thing. It's really a clinical diagnosis. It's looking at the signs and the symptoms of changes in menstrual cycle. It's looking at what other symptoms she may have in terms of hot flashes, in terms of disruption in sleep and all of those things. It's the difference, the clinical or definition difference between it is, have you not had cycles for 12 months? And I think that is simple, like it sounds simple, like there has to be something more for that. But no, it's clinical either way, and there's a strict definition that it is that's for it. But the treatment of both perimenopause and menopause can differ. Or it could be the same. It just kind of depends on what we have
Mhm.
going on.
Gotcha, 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 gotcha. So thank you so much for sharing that. So in some of your writings, you've highlighted the disparities in diagnosis and even care for women when it comes to menopause and perimenopause. As you have seen over the years, what do you think is causing that, and why?
Yeah. I think part of it is the way that things may look differently culturally for people, as well as a woman's own baseline health, which can definitely shape her experience in the transition. Okay. Um, so for women who, like, just say Black women, right? The biological differences, and research shows us this, is that Black women are more likely to experience more frequent and severe hot flashes. We know that, okay? Data
I
shows us that. Those symptoms often last longer, okay? But when we talk about access to things, at that same time, we know that women are experiencing more severe symptoms. We know that there's also the issue of access and bias. So, Black women are
absolutely.
less likely to be offered evidence based treatments like hormone therapy and more likely to have their symptoms minimized. That's the disconnect, right? That's how it's showing up differently for
Mhm.
Black women because, in response to that, often Black women are like, well, I'm just going to grin and bear it.
Yeah.
And nobody expects other people to do that, okay? At the same time, I talk about baseline health for women, right? So that definitely
Right.
shapes the way that they experience. We know that Black women have higher rates of conditions like fibroids, hypertension, metabolic disease,
Yes.
cardiovascular disease. That can complicate management decisions as well. So it shows up differently in the way that you experience it, but then also in the treatments that's offered as well.
Yeah.
Okay. The same thing if a patient has PCOS, right? So they
Mhm.
already have, or polycystic ovarian syndrome, excuse me, they already have irregular cycles, right? So recognizing the symptoms of perimenopause becomes a little bit more complex because maybe we can't depend on your cycle to tell us what it is because it's already irregular anyway. Women with thyroid disease, right, may
Yes.
have
Yes.
overlapping symptoms like fatigue and weight changes.
Yes.
That makes it harder to further delineate the disease. Same thing with mood disorders and things like that.
Yes. What about women who may have even we have somebody who's asked this question. What about those who have had partial or complete hysterectomies?
Yeah, that's a great question. I just want to take a moment to just define some things. So, a hysterectomy is removal of the uterus and cervix. Like that's a hysterectomy. Okay. Partial hysterectomy, I think sometimes people mean removal of adnexal structures like the ovary and the tube. Okay. But that's something called an oophorectomy or a salpingectomy, not a partial
Hmm.
hysterectomy. If we say partial hysterectomy, that means a portion of the uterus or a portion of the cervix was removed and still is left behind, but it has nothing to do with the ovaries. I just want to clarify that just
Yes.
for
Thank you.
education.
Thank you.
And
Yes.
so I think what we're asking is that people who have had partial hysterectomy. So if they've had a and what that means with my experience in speaking with women is that they mean like that they've had like an ovary or something like that removed.
Mm.
That does or can affect the timing of perimenopause and menopause. We know that women who have had surgery and the adnexal or have had a hysterectomy, even if their ovaries are left behind, can sometimes enter the menopausal transition earlier than other women. Okay.
Mhm. Mhm.
Um, if women have had a hysterectomy, like I said, they can enter um, into the menopausal transition a bit earlier. Women who have had one ovary removed can enter into menopausal transition earlier. Women who've had their ovaries removed early, okay, the absence of ovaries means that you have no more estrogen and progesterone that is being produced, right? So now you're automatically in menopause because there's no estrogen, or but it's surgical menopause, not the natural transition that a woman will go through later in life, if that makes sense.
Yeah, yeah, that does. That does. Well, you have enlightened us. All of our light bulbs ought to be on at this particular time. So thank you for taking that moment to give us additional insight because because I know I had one thought too about what partial hysterectomies were compared to what they actually are. So even I didn't want to go here right now. I'm gonna say that. I'm gonna say that for later. So
Okay.
so when we talked about some systematic gaps already. But in these systematic gaps, and even in when you begin to think about the technological age that we live in,
Yeah.
what is still causing us to be so underinformed when it comes to the transitions of life? I often have the conversation with Jamie about how this generation, I'm Gen X, and so that there are a lot of things that I feel like our parents did not deal with that we are now have shooting in our face, like, "Hi, deal with me." And I feel like the transitions of life, as opposed to just calling it the change, are some
Hmm.
of those things. So, what do you think? What do you think, or what is it that you are seeing that continues with all this technology and all the information is out there that's still causing us to be underinformed?
I think it's the issue of trust. And
Mm,
also an issue of education, because I can put anything before you. Like I can look at any news site, any website, whatever, but do I trust the information that's being shared? Do I
my
trust
man.
the person that's sharing it?
Yeah.
And that's so important, especially when you look at the systemic biases and racism in the medical system, and historically what has happened. I understand that. Like I understand. Do I really trust
Yeah.
what you're saying? And then
Yeah.
it's like, if I do research it on my own, is the research that I am getting or the information that I'm getting, is it actually accurate or true? So the
Mhm.
biggest gaps there are education, and I think it's on both sides. I mean, that's more so the patient side. And then on the provider side, it's like we have to learn to recognize that things show up differently for certain people, right? We
Absolutely.
have to do
Absolutely.
that. And then not only must we recognize it, we got to respond.
Yeah.
We got to respond to the
Yeah.
information that's being presented by the patient, the symptoms that they are expressing. And I think there is much work to be done
Yeah. Yeah.
on that side.
Yeah.
Add that into the constraints of the medical system where the visits are
Yes.
short, the symptoms are complex and multifactorial, which really makes it easy to oversimplify or easy to dismiss, right? I can tell you now, the menopause visits I have, they can't be 20 minutes. Like we just not.
Yeah.
And
Yeah.
so it's just not gonna get there, right?
Yes, 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 absolutely, absolutely. I often think about just the experiences. I've had the blessing of living in other communities with with probably more advanced healthcare than what we may even have here in our community.
Hmm.
But I still always find that there is a gap. There's a gap, and the what you did on Karen last week, who may have come in with the similar symptoms, is not the same thing you can do on Rhonda, who is wondering, what is going on in her body, because she has this what appears to be
Yeah.
an inferno going on, and
Yeah.
so being able to dig a little bit more and give your patients a little bit more the information, the education, just so you're saying, has really worked, I know, on my own personal wellness journey to empower me to do more. And a lot of that started, Dr. Shaw, well, what I was putting in my mouth. I'm just going to keep it real
Hmm.
with you. What I
Hmm.
was putting in my mouth. And through that and constantly educating myself and going to ask some questions when I need to, it has brought me to the point of where when I start hearing other women talk about the things that they are going through, that I in turn want to share information with them to help empower them to make the better decisions, to make the better choices and things for ourselves. Because, like I said earlier, we all got stuff to do, places to
Oh,
go to get there. And we need to be able to get there in our healthiest self as possible.
absolutely, absolutely. And
Yes,
I love that you said that feeling empowered, and that's really what it's all about. That's really what that patient physician relationship is all about. Understanding community, trust amongst each other, right?
yes,
And
yes,
making sure that the patient feels heard. And my job is to educate you so that you feel empowered to make a decision about your
yes,
health.
yes,
I don't,
absolutely.
I said, man, my patients know I say this all the time. Like I make recommendations. That's all I can do. I
Yeah,
educate, make a recommendation, but the decision is ultimately yours. We're not forcing you to do. We're not going to do that, because when you feel forced to make a decision, or when you feel like you don't have a choice because what someone is saying to you is all you got, and whether you understand it or not, that's not good.
no,
That's not good.
it's
So we
not.
need to keep having those conversations until you
It's
do feel educated and ultimately empowered to be informed, to make an informed decision and choice.
Yes, absolutely, absolutely. Thank you so much,
Absolutely.
so much for that. So many women, we're going to go into talking a little bit more now about some of the things that are associated uh, with menopause and perimenopause. We hear time and time again. So, some of those things involve brain fog, anxiety, and fatigue.
Yes.
When women are experiencing these symptoms, what is going on with us hormonally during this time?
Yeah, this is a great question and also a hot topic. And so remember, I'm going to go back to this. The brain tells the ovaries what to do, the ovaries tell the uterus what to do. The ovaries
Yes,
secrete estrogen and progesterone, right? And remember, those receptors are everywhere among the body, not just in your uterus. And the reality is that we know that estrogen has significant effects on the brain. It influences neurotransmitters like serotonin, dopamine, all of those things, which help regulate mood, focus, attention,
okay.
motivation. And so when we're in a period of estrogen decline or absence of estrogen, those systems are going to be affected by that, right? We know that estrogen also plays a role in sleep regulation and temperature control. And so when we're in perimenopause and these estrogen and progesterone levels are fluctuating, sometimes dramatically, it's affecting those pathways. It's affecting our GABA pathways, which can affect mood, which can cause us to have increased anxiety, increased irritability, poor stress tolerance, poor stress response, and even our sleep, right? And so
Yes,
you pair all of those things, and we know, well, I'll say me, a lack of sleep is a thing, right?
it is. It
It's a
is.
thing. And
Yes,
so you put anxiety or mood symptoms with lack of sleep. Yes, our brain is going to be foggy. We're
yes,
not getting the proper rest that we need. And
yes,
in perimenopause and menopause, that reaction can be real. It is very much real, but it also heightens and intensifies the perception of fatigue as well, which I think is really important to know too. And so I say all that to say all of the instability can disrupt these symptoms and get disrupt the systems and get an increase in the symptoms that we're seeing.
yes, yes, absolutely, absolutely. So we have a question from the audience from Ashley, and her question is: so how can women begin to prepare for perimenopause? Dietary, herbal supplements, therapy.
Yeah, so that's a great question. I think the first thing that women can do to prepare for perimenopause is to educate themselves about the stage. Know what symptoms you should be looking out for, know what could potentially happen during this stage. And then I love the question about therapy. I truly believe in holistic care. I tell people all the time a pill can help. There are some treatments that can help, but really, there are some lifestyle changes that come along with that as well. Therapy is an excellent one because it helps us to begin to train our brain about how we think about this phase of life. I mean, if you ask other people about the change or you ask your family members about the change, like, oh, that was terrible. Oh, that was horrible. I don't know how to
Yes,
that it's like that's the way they're hyping us up. So we gotta calm down, take that down a little bit, and say, how am I going to prepare? What do I need to do to train my brain
yes,
about
yes.
how I perceive this, how I think, how I'm going to shift and pivot in this stage of life? And I see so many women. We have this conversation often. There is sort of a dying or funeral for the old self. When I was 20, I
That
could
is
do
so
X, Y,
true.
and Z. I can
So true.
go over here and I can go all night long, Dr. Shaw. And then now that I'm 40, I can. Like I'm juggling all these things. And my response to that is, who told you had to keep juggling? Like
Ooh,
who told you had to keep doing all of those things? There comes a time where we have to learn to pivot
ooh.
and prepare ourselves for that transition in that pivot.
Yes,
So I love
yes,
that piece of it, right? A dietary, absolutely. It definitely starts with the things that we're putting in our body because we know that metabolism slows in the
yes, it does.
perimenopause and
Yes,
menopause
Lord.
stage. So what
Yes.
we did to lose 10 pounds at 20, it ain't
Come
working
on.
at 40. It's
And
not,
still
it's
eat
not.
McDonald's.
It's just
Yes,
not gonna do it. And that's biology, that's hormones, because your body is like, look, I don't have energy and time to waste on that. We're
yes,
trying to make sure that we have enough of this hormone. What source that hormone or what can be something that is like that hormone if I store it in your fat and that fat, that estrogen is like estrogen, those kinds of things.
yes.
So it's your body's working against you too. So we have to pivot and change how we eat, how we what we eat, how we even exercise. Whereas
Yeah.
before we were doing cardiovascular things, now
Yes.
we need to pivot and
Yes.
shift to strength training
Yes.
because why?
Yes.
Muscle mass
Yes.
decreases, right?
That's right. That's right. That's right.
And all of those things. So I could go on
Yeah.
and on about that, but all of those are great. And then I want to touch a little bit about supplements because we said that. Now I'm not a I, supplements are okay, okay, if you are deficient in some of the things, right? But I'm never going to tell you that you need to be taking, zinc and this, and this, or if you're not deficient in it, it's probably not going to help with it, okay? And so we just need to watch that and be careful because there are some things that are over the counter that contain ingredients that are similar to estrogen. That if you do still have a uterus, and are taking some of these things, it can stimulate. And I have seen it stimulate the lining where the tissue becomes abnormal. So I would say
Mhm.
for any dietary supplement that you're thinking about taking, make sure you discuss it with your healthcare provider. And I think that's how I can get around that question. That one, okay, with a very legal answer.
Understood. Understood. Well, thank you so much
Of
for
course.
sharing such great insight. And ladies, if you are enjoying this conversation with Dr. Miles, show her some love in the chat. With some starburst because she is definitely you all sharing information that is going to empower us to better embrace because that hit me. I'm a personal development junkie. And so when you start to talk about being better able to embrace this transition of
Yeah.
life, not necessarily mourning what once was, but
Hmm.
embracing what comes along with that. I think that is so awesome because we many times are wanting at 42 want to still be able to do what we did at 22 and
Yes.
baby the body is not allowing
It's
that.
not gonna do
It's not
that.
allowed.
and
It's not
that and that's
allowed.
okay. That's
Yes, and
okay.
it is okay. Yes, absolutely, absolutely. Thank you so much for that. So, what are some of the biggest myths about many menopause that you wish people would unlearn? What are some things? Yeah,
Yeah.
and
So
and
I
particularly, I'm going to say particularly in our community. Yeah,
Yeah,
yeah.
yeah. I think that one of the major things is that we tend to associate menopause with hot flashes, and
Mm-hmm.
that's it. Okay, so I got to get rid of these hot flashes. And once I get through these hot flashes and probably sleep a little bit more, things will be okay. Okay, but the reality is, yes, hot flashes are there, but menopause and the menopausal transition really does affect cardiovascular health. It affects bone mineral density. Okay, metabolic health. We should be making sure that those elements of our health and our screenings and things like that are up to date. Okay, it's not just about treating the hot flashes, it's about what else comes with the decline in estrogen. We know that when estrogen declines, our
Mm-hmm.
cardiovascular risk increases. So, how are we preparing for that? How are we assessing that? Are we making sure that we have our yearly exams and our lipid screenings?
Yes,
Are we at risk for osteoporosis? Are we having our bone mineral density screenings? Those are the things that we also have to stay on top of. And we as women, we're so used to taking care of everybody else but ourselves. And we see
say
the
that.
most,
Say that again, Dr. Miles.
we
Say
are
it
so
again.
used
Yes,
to taking care of everybody else
yes,
but ourselves. And
yes.
oftentimes, I see and counsel and treat women who, when they were pregnant, they went to the doctor. Like that's fine. But then after that, it's like, well, I didn't have a reason to go to the doctor. But we have to come up out of that too, as well,
Yes, so true.
making sure that our health is that good. The other one is that hormone therapy is like unsafe or broadly unsafe. And I will say this, while it is not for everyone, for many women, it can be safe and effective when used appropriately. And we have parameters for that, right? For healthy women who are under the age of 60 or within 10 years of menopause with an acceptable risk profile, hormone therapy can be considered safe and effective, right? And those risks depend on age, time around menopause, the route and formulation that we talk about for the therapy, and then cardiometabolic risk, breast cancer risk. All of that needs to be assessed as well. And then the last one that I'll talk about that I want people to stop saying is that this idea, this concept that women should just endure during this process. You don't have
Oh,
to endure.
yes.
We can truly thrive through this transition because we know that this is something that's hormonal, it's biologically driven, and it can affect our work performance, our relationships, our health. And so we don't tell people with asthma and diabetes to just tough it out. We don't do that.
No, we
So
do
we
not.
need to apply that same energy here through this
Yes.
transition.
Absolutely, absolutely. I think that is so important. What's it many times what science is saying. I think we have a tendency to undermine it or minimize it because if we're honest, be very very honest with ourselves, we don't always believe it, and
Hmm.
so we just feel like, oh, it's something. Oh, I'm tasked with or plagued with or whatever, and I just got to stick it through. But no, like
Yeah,
you're saying, there are options that should be helping us to do better, to make better decisions, make better choices, and even as needed to embrace some form of therapy for ourselves.
absolutely.
And I'll just be very transparent. That became a game changer for me, Dr. Miles, in me losing weight,
Hmm.
and I take the shot. Yeah.
Hmm.
And so
Hmm.
it's getting the hormones aligned. So once all of the hormones and things got back in place, the weight start coming off, and I do work out and things of that sort. But I was working out, not an ounce moving. But it,
Yeah.
it it helped, and it was something hormone therapy was something I was running from. But once I decided to embrace it and the transition, hey, I got what I needed and feel much better as a result of that. Yes. Yes.
Yeah. Yeah.
Yes. Yes, absolutely. And so, so you've given us many things as it relates to dealing with the perimenopause as well as menopause itself. So, how can we begin creating like our own personal care plans when it actually comes to the easing of symptoms and even just this transition of life?
Yeah, so I ask people this question. It's like, if you had a magic wand, if I had a magic wand as your physician, what could I cure for you?
Hmm.
What symptom is the most important that you would like to treat, that you would like to attack first? And the reason why we do it that way, and it's part of creating the plan, is because oftentimes it takes 50 years to get to menopause. It's not going to take 2 days to reverse the symptoms. So we have to pick our starting point, and it's a journey to get to where we feel better and more comfortable, and we're at our best selves for whatever our best selves is in this transition of life. And so I say start with your symptoms and your priorities. Are you struggling with sleep? Is it mood? Is it hot flashes? Then we pick that, and then we say, okay, now what tools do we have in our toolbox based on your medical history and risk factors that we can use to address that? And from there, we build a plan that can include treatment or therapy or medicine, but also includes lifestyle changes, right? It can include
Yes.
non-hormonal therapies as well. And it really just depends on the individual. So we pick our starting point, and then we create the journey from there.
Yes, yes, absolutely. That's those are some really some good points. Where have you seen just overall with your patients when they've adopted their own personal care plans? Where have you seen most of them having the most success with which particular things?
In terms of either therapy or lifestyle changes,
Yeah. Yes, ma'am.
yeah, I think we've had patients to have a combination of both. Of course, there are some things that are just the gold standard, like for hot flashes, like hormone, estrogen is probably the gold standard. But for even those who risk out of treatment with hormone therapy, um, cognitive behavioral therapy,
Yeah.
non-hormonal treatments. Again, reframing the brain of how we think about it, um, reframing how we respond to what's going on or the hot flashes or when they have happening. For example, I talk a lot about bringing my fan, because I have a fan. I don't go nowhere without my fan. And so, yes. I don't go
Yes,
nowhere without my fan, okay? I got
yes,
my fan everywhere, and I ain't ashamed. I am
yes,
not ashamed
yes,
of that, okay?
yes.
So, putting some character, but also some sense of normalcy around
Yes,
things that you can do, right? The cooling sheets, the bamboo sheets, the all of these things that can help. But I think the people who have the most effect are ones that it's holistic. So it's a little bit of treatment, but it's also the life channel changes as well.
yes, yes. Good, good. Thank you so much for sharing it. We do have a question in the audience that says, "How often should we get our hormones checked?"
Ooh, y'all not gonna like me for this, but I'm gonna say it. I you shouldn't. So here's the thing.
Ah,
Menopause or perimenopause is a clinical diagnosis, and you hear me keep saying that, right? And the reasons why I say this is because remember how I told you that sometimes the ovaries are using up their PTO and sometimes they're working?
yes.
So if we decide to check hormones during the time when your hormones are working, when your ovaries are working, it's going to look normal on paper. But that does not negate the symptoms that you're having or the fact that you could be eligible for treatment. So testing your hormones during that particular time period didn't help me. It didn't help you
Mm-hmm.
because I can easily say, well, you're fine. And I think that that's where a lot of people have been dismissed when they're still having symptoms. And like, but they told me
Oh,
my hormones are fine. Well, maybe you're doing the period where your ovaries are working. But if I were to take you weeks later where your ovaries are on PTO now, especially during this period menopause process, it may look a bit different. Does that make sense? So that's why I say
yes.
hormone lab checking is a little bit of a slippery slope. Let's look at what you're experiencing. Let's look at the timeline. Let's look at the age. Let's look at all of these things and kind of make a decision clinically about what best fits you. Now, if you are, postmenopausal, are there times that we can use labs to kind of check the status of where you are, especially if you're like 49, 50, you've had surgery before, we aren't sure, kind of, absolutely. I'm not saying that they're completely off the table, but I'm saying I would prefer to listen to you and listen to your story, assess your history, and go from there and let that be the leading deciding factor rather than hormones. Because even once we start
Mhm.
treatment, we don't treat to a hormone level. I'm going to treat to how you feel clinically.
Ah,
And I think
yeah.
that gives you the best well-rounded care.
Yes, yes, yes.
So take a second to pee, okay?
Yeah. Yes, I could definitely see that. So it's not it's not a cookie cutter approach.
No,
It's not a
no,
one
there
size
is
fit that
no
fits
one
all.
size fits
Yes,
all plan for menopause or
yes,
perimenopause.
yes. But it from just listening to the approach which you say you use, it takes a bit more of deep diving to find out what else is all going on with that particular patient. And that's what we need. We need more healthcare providers who are doing that. Thank you so much, Dr. Shaw. So
Absolutely.
I'm going to do a little switching. We have about 13 minutes left here in our interview.
Okay.
Community, if you all have any more questions, please be sure to drop them in the chat. We want to make sure that everybody gets all of their questions answered before we leave here on tonight. Okay. So, if you come across like your patients and many of them are feeling as if they are losing
Mhm.
themselves during this transition. Um, how do you normally counsel them, so to speak, in that particular area because it is a transition?
Yeah, yeah. And really that transition can really feel destabilizing, especially for
Mm,
people who are I see a lot of women who are, you know, I'm at the peak of my career. I have done everything with my kids. My kids are out of the house. Like I'm doing all of these things and I feel like inside I'm crumbling, right? Because I'm not recognizing who I am in my body. I'm not recognizing my body. I'm not recognizing the responses that I'm having emotionally. This does not feel like me, right? This does not feel like me. And so I think it's a good time, like we talked about earlier, for women to begin to reassess priorities, to really set boundaries and redefine who they are in in this stage in life. And then the feeling is very, very real. And I hear it very often with patients because it's again treated like a loss, right? And I've talked about this before, but I think the way to reframe that is we're moving forward. We're not going back. We're moving forward with purpose. We're moving forward with intention. And where these hormones are fluctuating, where I'm feeling the effects in my sleep, my mood, my energy, and all of that, I need to make sure that I show up for myself in such a way that it feels authentic and I feel understood. And
Yes.
sometimes that's also setting boundaries.
Yeah. Oh,
It's also
yes.
educating my family members around this too, whether that's my partner, my spouse, my children, or someone else. Like, look, this is what's happening to me, and this is the boundary that I have today. I have no capacity for anything extra because I am
Mhm.
redefining where I am and what I'm doing.
Yes. Yes.
And that's hard. I think that that is very hard for women to come to grips with because we're so again used to taking care of everything
Yes.
else.
Yes. Absolutely.
Yes.
Yes. Okay. Thank you so much for sharing that, Dr. Shaw. I think the component of our lives when it transitions from us being caretakers or the person who sees
Mm-hmm.
after everyone to actually moving into giving more time and attention to ourselves feels very strange and foreign. Many times because society has said that you don't do that, and particularly for women, and sometimes with uh, uh, the South, and how sometimes our culture is played out here. Yeah, particularly in the Bible Belt. Yes. So we have a question from the audience. It says, "Are digestive problems tied to perimenopause and menopause?"
Yeah, I think that that's a great question. And the reality is maybe there is some evidence that shows that sometimes the way that our body processes hormones, particularly estrogen and progesterone, those receptors are present. It can affect if there's decreases like gut motility and function, and can also sometimes have an impact on the microbiome in the gut as well.
Mhm.
And so some people will see some changes in their GI tract as well. But I will say it's very important because as we age, those things also happen too. The gut slows down. We are increased risk for GERD and all of the other things. And so it takes a workup. And I tell all of my patients, I don't just hang my head on it's your hormones. You never heard me say that. You're just not. I think we
Yes.
can rule things out and rule things in. But to answer your
Mhm.
question, yes, there can be changes that are associated with that. Depending on age, there are some other things that we are at risk for, and we need to make sure that we are able to differentiate the two. So we don't want to put it on just your hormones when actually it's something else.
Right. Right. Thank you so much for giving us that answer there. If there has been one particular thing that has empowered you in this conversation tonight, I want to encourage you to put that in the chat. I used to have a former pastor of mine. He would always say, you should have gotten your one sentence in the sermon that was meant for you. And
Yeah.
so, what would be your one sentence, ladies, who are joining us here in this conversation? Drop that in the chat and just let us know. We'd like to highlight those before we close out for the evening. That one thing that Dr. Miles has said on tonight that has maybe empowered you, maybe shifted your thinking, that may have caused you to rethink some things during this transition that you may be going to or getting ready to go into. Share that with us in the chat, and we'd love to hear that those things from you before we leave. And so says here, I love that she said that she would rather listen to you to assess where you are and maybe going on. Yes, yes, absolutely. Thank you so much for that comment. So here's maybe a next to the last question. We'll see see what comes up. And so up there, they're putting them in there. Advocate for yourself. Yes. by Jerica.
Yeah.
Yes, advocate for yourself. Yes. So, Dr. Miles, here we are. It says we're at the end of this great conversation. Again, we thank you so much for being here on this evening and empowering us with such great information with this transition. And I would also like to say that you've also taken the mystery out of what is beginning to go on with our bodies, and to also be able to embrace this new season of life, just like we would if a new season said we were moving somewhere, you know.
Yeah.
Yes, thank you so very much for that. So here's my question for you: how can we begin to reframe menopause from something to fear into a phase of power, wisdom, and renewal?
That is really, really a great question, and I think it's a lot of what we've explored tonight. We really need to move away from fear-based narratives, right? We
Yes,
should not
yes,
dread this stage of life. It's a natural transition, and I always want to encourage women that with the right support, it really can be an empowering time. Like it can be a time of clarity, confidence, renewed focus, because sometimes for the first time, you have an opportunity to focus on yourself. There's nobody else with the competing because at this stage in life, a lot of people, if things are people are out of the house, you have more time, you can do some of these things, right? And so I think with that and with that shift in focus, a lot of women that I see start to feel really more in control than they have felt, right? One of the other things that we need to do is really just start by telling the truth about what is happening, what is
mm,
going on, and talking about it and sharing about it. It's not
yes,
anything to be
yes,
embarrassed about. It's
yes,
really not. It is like my mom said, if you live long enough to tell the story, you'll get that too.
yes.
So
You
you
can get there.
right? And so let's move from this is a decline in women's life, right? It's a transition, but it's not a decline. It really is not. The
Yes,
other
yes,
thing that I really want to encourage people to do is to become more educated and empowered during this particular part of life. So no longer are we silent, but we're moving to an area of understanding. We want to know what happens with our body. We want to feel empowered to make decisions and choices about those things that are happening to our body.
yeah,
And really
absolutely.
just aligning ourselves with the best that we can be in life. And I think that there's power in that.
Yes, absolutely, absolutely. Wow, wow, ladies and gentlemen, you have heard it. Dr. Miles, we thank you so very much for being here today. And before we close out, I would love to go through some of the things that
Yeah.
they're saying here. Very empowering. One of them says, "Advocate for yourself." And that was from Jerica Jones. And Jan Brown says, "Look at everything." And she has everything in all
Yeah.
caps when you're assessing your medical issues you're having. Ashley Doyle says, "I love that Dr. Miles spoke on not being afraid to set boundaries as you're going through your process." Yes,
Yeah.
yes, so true. Christina Turner says, "I simply appreciate hearing specifics about all of the symptoms that we experience from a provider." Yes, yes, those have been very enlightening today. Beverly Lewis says to take control of your body. Yes, indeed.
Yes.
Yes,
Yes.
indeed. And then last one from Ashley is, I know, she says, "I know we're out of town. Perimenopause and pregnancy." Hold on, it's moving. Okay, there it is. The weight of it mentally, especially if you don't know exactly what you're going through. Yes, absolutely, absolutely. Because if you're uninformed, you're
Yeah.
you really don't understand what's going on with your body. Or, as Dr. Shaw has said to us today, if you also don't trust, and that was a huge standout for me today, being able to trust your medical providers as well. And here's something else. It says Dr. Shaw is also a sponsor for, yes, for the Black Women's Wellness Luncheon. That's going to be happening on next weekend, which is April the 25th. So please make sure that if you want to get a seat, you want to be in the place, that you must go to the Eventbrite and just research NELA Black Maternal Health. and you can RSVP your seat. It is free. It costs you nothing, but you do need to reserve your seat for the day. And Dr. Shaw-Miles, we thank you so much for pouring into this initiative in Northeast
Absolutely.
Louisiana as well. So if we don't have anything else, again, leave us with one closing, two or three closing thoughts that you may have. You may want to leave our audience with.
Um, for this, I say, for any woman that feels as though they are not being heard, that they don't understand, would like more information, please seek out reputable sources for that information. Whether that is through the NELA website, or whether that's through a trusted resource, or through your primary care doctor, or in referral to an OBGYN. Please do that. You are so worth the investment in time and exploring your symptoms, okay? Don't let anyone shut your mouth about it. Keep seeking until you find someone who understands and willing to walk with you through that journey. Okay, if that makes sense. And there are people that are out there for people who are experiencing perimenopause and menopausal symptoms. There are menopause society certified practitioners that are available in the area, and all of those things. Seek them out. Seek them out. Do not go through this process alone.
Yes, absolutely. Absolutely. Well, thank you all, everyone, so very much for being a part of this robust conversation that we've had on this evening. I am so excited to have had this opportunity to share with you, to talk with you, and to also to glean from you as we have been with you on this evening. One of the ladies said this is time well spent, and I most
Awesome.
definitely agree. So if you are in and around the Monroe, Louisiana area, we would love to have you join us again on next weekend for the Wellness Luncheon, which will be part of the culminating events for NELA Black Maternal Health week and month because we've
Yes.
celebrated all month. Please go to Eventbrite, look up NELA Black Maternal Health, and get your seat there. And we'll look forward to seeing you there and continuing these conversations. Thank you again, Dr. Arie Shaw-Miles. God bless you. And thank you so
Thank
much for the
you.
work that you do in our community. Everyone have a
Thank you
great
so
night.
much. All right. Good night, everyone.
Good night.